because things are so much more clearer with that. Faster recovery times, obviously, because the incisions are lesser and the procedures are less invasive. Obviously, you've got to know how to do a knee arthroscopy. I think young consultants doing their fellowship exams should have some kind of exposure in this. And in the future, I think majority of you, whatever you do, if you're doing knee surgery, hip surgery, you should know how to do some basic, at least meniscal work and diagnostic arthroscopies and so forth. But it can cause problems. So iatrogenic articular damage, especially around the notch region, your lateral notch, is very common. If you don't know how to place the trocar in, instrument breakage can cause. We've had a few issues here in Mayo, and we deal with them. The instruments are not as good. The second-hand instruments, they're liable to break more here. Infection, neurovascular injury, it's very rare to get neurovascular injury. Quite rare to get infection, but you've got to be careful and do your planning before. So we're going to talk briefly on this. Positioning, I prefer the B position, the one on the right side of this. Some people prefer to have this sort of hanging type or tibial, like you do a tibial nail type position. But I feel this gives me enough freedom. There's various people who work with me know there's various ways we can have this. Have a look at this. So the next, we go to the setup really for knee arthroscopy. This is a pretty standard setup. I'm going to go through a case we did at the Mayo very recently, and we go through short 1-minute videos. So you guys, because what I feel is, just before my trainees come closer to their exams, all of a sudden we've got about 8 or 10 people watching me do an ACL here, which can get a bit arduous. So we're going to go through some of the important points that the examiner may ask you, and you should have a sort of an insight on that when they're asking you what the stages are and what to expect. Just broad points, and we can go through some more details later on. So firstly, this is the setup, right? So we're doing the right knee. So screen and the tower on the other side. We are a public hospital. We don't have currently a pump, so we have a Purosol 2 liter and 3 liter one. At least try to keep it around 6 foot and have it wrapped with some total, give yourself some pressure. Especially during, meniscus is not an issue, but ACL work, you're creating a lot of tunnels and so forth, so you do need pressure for visualization. And I routinely put some adrenaline in my Purosol as well, just one vial. So I use a hamstring graft for pretty much all my ACLs. This, if you look at it here, on top, we made it slightly bigger here, but you have a semitendinosus on top, gracilis on top, and semitendinosus down below. So you can see the sartorius, we've got it nicked underneath that the artery, and the gracilis on top, semitendinosus delivered from there, from the pes insurans. I'll just stop for a minute. Start back up. So this is a typical hamstring graft that we get. Okay, so we use a semitendinosus and a gracilis tendon routinely for this. So you guys should be aware of the lengths that you should have. I like to have the length, at least the minimum length I should have it would be 9 centimeters of this graft. So this is a quadruple graft. You take 2 long tendons and what you do is you fold them together. So 4 strands become. So 2 strands, you fold them back together. Normally the gracilis is sandwiched in between the semitendinosus. So you have a total of 4 strands. The length should be at least 9 centimeters for this graft to be functional and able to be fixed at its position. And which includes, by the way, you need to have at least 2.5 centimeters of the femoral socket and at least 2.5, ideally 3 centimeters of the tibial socket. And on top of that, you need to have, how much is it? You guys would know how much is a normal ACL. It's about 3.2 centimeters, somewhere around there, right? So if you sort of add all these three up, you need to have at least 9 centimeters to have a functioning ACL. Otherwise, the tunnels and the fixations may be compromised. And the width of the graft should ideally be 9. 8 is fine. 7 is, I don't like 7. We like to normally otherwise beef it up with some other mechanisms, but we like at least an 8 graft, width graft. This was a 9 graft that we did, so we made it a 9 one. So that's pretty standard. Knee portals, and I've got a little video on this as well. You guys should be very comfortable with knee portals, and I see people are not really with their experience. So standard anterolateral intermediate I use for my meniscal work. Superior medial, superior lateral, we don't use that much, sometimes for removal of loose bodies and outflow tracts. And I use accessory posterior medial portal for if we're doing a multi-leg, such like a PCL and doing an ACL, so we use posterior medial usually for that. It's quite important to use it for visualization of the back of the knee and looking where the tunnel is to be safe as well, and clearance of the posterior capsule. So I've got videos here, just 1 minute sort of videos each. You guys can have a look at them. I think they'll be informative if you can hear them, and then we can talk about them later on. Basically, I hope that is relatively clear for you guys. So these are the portals that I normally use. I don't routinely use accessory medial portal, but some people use 2 medial portals. I only use 1, and I feel that I can do more than 90% time with just these 2 portals. And for the ACL, you use a very high lateral portal, and that's when you guys are doing your own ACLs as well. Very high as medial as you can lateral portal, so you'll be able to see the notch, as I think I was clear enough on that. So, and that's the things that I've sort of picked up over the years. So basically, and then we do a notch clearance. I won't bore you too much with that. But so this is the same case that we're ongoing. We've done recently here. So basically, that's the notch being cleared. And that's where the old tibial footprint of the tibia is, alright? So that's how we're doing the notch clearance. And then we use the needle. So femoral tunnel, what they may ask you about these critical points about the femoral tunnel, I feel are quite fair game in the exam. So we usually do the femoral tunnel for the ACLs through the medial portal, as I explained to you that I'm trying to get a gauge of how my drill is going to go, and then make my medial portal. So we do the drilling through there. And so we're trying to recreate the previous anteromedial aspect of the ACL, the anteromedial bundle. And that is routinely around 10 to 10:30 for this particular knee, and through 2:30 on the, if it's the left knee. You need to leave just a little bit of the posterior wall, and that's what I was sort of telling you guys from the wand as well. You can check with Shaver and the wand your hook, you can check how big back your posterior wall is. You need to leave at least 10 millimeters. So if you routinely, I have found when you use the drill in the femoral, if you're using it in the right way, right trajectory, the length of the femur for your drill is around 42 to 44. So you need a socket. We use interference screws here. You can use buttons and tight ropes as well, but you need at least a 10 millimeter of bony bridge between your socket and the edge of the bone. So if you're thinking about it, if it's like a 42, you need to don't go more than 30. You know what I mean? So you'll have 12 left afterwards. So you have a bit of bone left, so you have good purchase of there's no compromise laterally. Aim for a socket for, I aim for 30 usually, so I use a 30 screw. That's a very good interference, as long as you have an adequate graft length available to put 30 in there. And then usually I aim for a graft, size 9, and I use a beef needle to prime that. Anyway, so this is the tibial. I don't think we need to go through much of the tibial. So I'll just go through it. So basically, this is you can see this very well, and I'll show you where the tibia. If someone asks you where the tibia comes from, the tibial, you can see it top down, and you should be able to see this area over. So where it is, medial tibial eminence. This is the routine, right? You can see the stump. A lot of times you can see where it is. Clean that part of that off, and then you just put a drill through there and put your garboil through there. If you can't, then if you need some indicators, then you can just look at this. Look at this. This is the medial tibial eminence. It's usually just lateral to that, and behind the intermeniscal ligament, there's an intermeniscal ligament. So if you're looking at it, you've gone too far. If it's in that level, it has to be posterior to the intermeniscal ligament and just lateral and anterior to the medial tibial eminence. So that's the really go-to one for that. The tibial position. You can see this coming up really nicely. We call it a shouldering of the tibial guide. So it comes out in the shoulder. Some of it comes out in the tip. You need to check with your the company where is this coming out from. So, but you see, this is the old stump sort of the ACL. A bit of that left, so that's come out right from there. So that's a good indicator. Really, it's a good position. So then we're just going through this motion. We do the sockets. Then we use the beef needles to shuttle the suture, and then subsequently the graft, we tighten it. We use a reverse Lachman to tighten the tibial side of it. I do it around 30 degrees, and then we after cycling it. And then this is just before we dock. This is called docking of the graft, right? So this is the femur. So we mark that 30. The slice is sort of coming through, so we're happy with the way it's docked. We know our marker has been achieved, so we've got 30 docker. So this is good, and then we, as I said, we do the reverse Naqshband and put a screw. It's easy to put a tibial screw. You can see it, it's open. I normally drill the tibial, my tibial socket is through my graft side. Where I take my hamstring graft, I normally my incision for the hamstring is about this long, about 1 inch, and then I do my tibial drilling through there as well. So we don't need any more incisions for that. It just close up on that. I hope this will give you a slight idea of how we do things, and if the examiner asks you, you may just sound a bit smarter talking about this. So basically, and I do the graft harvesting. Number one, I am sure that this patient has an ACL. I do an EUA before, so examination anesthesia, the MRI mark is there, my assessment is there. I don't normally muck around and wait around to have a look at the ACL. I take the graft. You commit to the graft then, as long as you show it. And then you hand the graft over for preparation. In the meantime, you do all your meniscal work. If you want to do meniscal primer and have a look around the knee, and then you do the shuttlings. So post-operative, we can discuss these as well, but these are my protocols, so don't put much weight on the knee for the first 3 weeks or so, and partial weight there. Use icing, quads activation, heel stretches, and try to keep the knee as straight as possible, because the tendency is, because you've taken the hamstrings, you want to bend the knee a bit for ease, but that can cause problems and cause a bit of contractures later on and are difficult to rehab. And so in Pakistan, I use the wrong brace for 6 weeks and let the weight bear 0 to 90, and then at that time we start at the week 4 onwards, we start some closed chain exercises and quadriceps gradual strengthening program, and the patient is allowed to jog at 12 weeks and no sports till after 6 months. So ideally 1 year, then you can start. 6 months is the minimum. I normally try to stretch it to at least 9 months to 1 year before they can start pivoting sports again. Multi-ligament, I've got a couple of slides because Ali and these guys want me to put a couple of slides on multi-ligament, the current evidence, and I've had a look through that, through the literature. So what is the current evidence? This has gone up and down, to and fro, and different people have had their opinions over the years, over the last 2 decades. They had a lot of interest. It's not very common to get multi-ligaments, but when we do, what do? So we reduce the knee, number one, and then the current evidence is, or current practice that's commonly carried out internationally, is you wait for the first 6 weeks. Let things settle, right? Let your soft tissue settle. Put them in a cast or a brace, and don't allow any weight bearing. What it does is, after 4 weeks, at times, and a lot of times, it binds, the MCL gets healed by itself. The MCL heals if you don't put weight on it, if you put it in protect weight. So the MCL heals. Sometimes it's a very nasty posterolateral corner, you have to go and address that. But sometimes if it's partial or something, that heals as well. So you're left with, after 6 weeks, you're left, and in a range of motion brace, you're left with just to repair the PCL and the ACL. So it makes things a lot easier. If it's missed or if it's delayed, then you have to do whole reconstructions, and there are various things that we can do about that. But delayed reconstruction, post-rehabilitation protocols, I've got some from my multi-leg, I'll show you what we use here at the Mayo. And reconstruction, allo, autografts, we use a combination of everything. Pakistan, we don't have the allografts, so we use different autografts, TB. And so if both ACL and PCL are involved, we reconstruct both of them. And there's very limited use of repair. You reconstruct everything. You can augment on top, but you need a fresh tendon, essentially. You can't just repair a tendon. So graft options, what do we have? PCL reconstruction, ipsilateral contralateral cord stem. This is from the American Academy that they sort of recommend at times. In PCL, especially in the UK, Lars ligament is quite commonly used now. It's much tight, nice ligament. I had a PCL recently and we couldn't find that ligament here. So if anyone knows how to get one, please let me know. It's a French company, it's a hard ligament, synthetic ligament essentially. Because whenever you do a PCL, in the end, there is some laxity in the end because that's just the way the dynamics are. But that ligament actually does well. But anyway, if I do a multi-leg here, we use not my favorite, but the peroneal for my PCL and hamstring for the ACL. Right, so these sort of things, and there's a variety of things you can have justification for these what you use. So post-op, if someone asks you about the protocols, early return, full extension after PCL is the main important things, and with we use a PCL brace which has a bit of stress on the proximal tibia, so it's keeping it up to keeping the repair protected, and we are keeping it in a range of motion 0 to 90 for the first 6 weeks, close kinetic chain exercises with arc of motion, and aim to regain mobility and things in 3 months. So it is a bit of an uphill process, and you delay the jogging to 6 months, sports after 1 year, and this is the routine. You guys can have a look at that. This is what we use basically, and this is our thing. Looking at the bracing, range of motion, weight bearing, muscle exercises, and it's quite been well laid out in that respect.
So 12 weeks.
Right. Okay, so we can talk about this after this. Okay, so just a note on the ACL repair, guys. So there is not much clinical evidence on this. So if someone asks you about ACL repair, I don't do an ACL repair mainly, unless they're very proximal, they're very young. If it's a very proximal repair, you'll see a avulsion from the femoral side that has a lower revision rate. But lower meaning it's still 18%, right? So this is a meta-analysis of large recent meta-analysis of over 2,000 patients. So they say, they advocate reconstruction whenever possible. So this is the process of repair. We don't have to go through ACL repair. That's how we normally do it with this sort of law catheter. All right. So now I can answer any question you guys have.
So ये 2 स्लाइड बैक है ये
So कोई questions हैं आप लोगों को?